So we'll have a short class just to cover up all the topics that probably might have been left and maybe some part of understanding. So uh, we'll just revise the topics of molecular medicine and then follow it up with not exactly MCQs, but I have something different for you this time. Uh, how many doctors are here today?
11.
Okay, okay, all right. So basically, in medicine, we have all the topics deep down into biotechnology and genetics. So we did a lot of questions in the last class and learned about some techniques which are very important in diagnosis of certain cancers and certain hereditary diseases and certain congenital diseases, certain genetic diseases, and gene therapies and newer pharmacogenetics, which is coming up in a big way and is being asked in the exam. So these are the topics which are not even discussed usually and routinely in our MBBS and MD classes, but yes, they are important because they are a window into the future. So we'll begin with the genetic testing techniques. We begin with the most trivial of them, which we have been learning since a long time, that is PCR. So basically, the PCR is what? It amplifies the specific DNA sequences. So whatever DNA sequence you want, you put that small, it's called a piece of DNA. If it is there, you give them a medium. PCR is just like culture. We do culture of bacteria, we take the sample, we put them into petri dish, into a culture medium which we perceive that would be helpful to let the bacteria grow even more. Same way PCR, we take the DNA sample or whichever sample we have and put it into our medium in which there are multiple nucleotides and nucleosides which are available for ready replication, and then we have a polymerase enzyme, DNA polymerase in it. What happens is this DNA polymerase, it tries to get the nucleotides and attach them on the sequence as far as the present, I'm not getting that word, that small part of DNA, the probe, the DNA probe which is delivered into the medium, and then it amplifies those sequences only and helps us to diagnose those conditions which are very difficult to diagnose, like HIV. Sometimes HIV, you can diagnose only by presence of the viral particles. And how do you define the viral particles? If the RNA or the retro RNA or the DNA is present. Same way these days, tuberculosis. If TB PCR is positive, that means the tubercular bacteria was there at the time of sampling. That is why its DNA was there at the time of sampling. And of course, genetic mutations. Then comes fluorescence in situ hybridization technique, which is called FISH. So in fish, this fish detects chromosomal abnormalities. So chromosomal means big chromosomes. For example, BCR-ABL translocation in acute myeloid, in chronic myeloid leukemia, presence of HER2 new gene in breast cancer. This was fish. Then comes southern blot. Now, southern blot is basically for DNA. So it detects DNA mutations. For example, multiple repeat expansion, trinucleotide repeat expansion like Fragile X syndrome, Huntington's disease. These are the diseases which utilize southern blot to diagnose. So many times this question comes, what is southern blot? What is northern blot? What is western blot? What is southwestern blot? What is so northwestern blot? So southern blot is DNA, western blot is protein, and northern blot is mRNA expression. So northern blot is where we measure the mRNA expression levels. Where should it be used? It should be used in enzyme deficiencies. Why? Because enzymes are all proteins, and proteins are produced by the process of translation. And translation is done on a mRNA which attaches to the ribosomal complex. So if the mRNA is there, only then the protein will be there. For example, if I say that a patient has a certain enzyme deficiency, then how do you define that this protein is not being synthesized only if the mRNA levels are not there? If the patient does not have any mRNA, that means the gene is deficient. But if the mRNA is there and the protein is not being synthesized, then we find that there is a problem with the translation. That is, mRNA is not being translated into the proteins. But if the gene is deficient, then mRNA will also not be there. So if you check the northern blot and you do not find any mRNA respective to that protein, that means that directly it tells you that this is a protein which is totally deficient in this person. And if you are having a enzyme, having a treatment, a medicine, a molecule which is to be given to that person which utilizes that enzyme, then what will happen? That medicine will be rendered useless because that enzyme is not there. Because either we cannot check that enzyme level in the blood, or we are not getting the mRNA also in the northern blot of the patient. Western blot is to identify the proteins. Now it uses antibodies, for example, HIV confirmation, prion diseases. These are Western blots. So you identify antigens like HBs antigen, hepatitis B surface antigen. Students don't ask how is that done, sir. That is done by blot method, Western blot, because that is a protein, and protein is identified by Western blot. Then comes the easiest test of all, which is ELISA. Now, ELISA detects all the proteins and antigens. It is easier to perform. Everybody is doing it. ELISA changed everything. You can diagnose almost so many infectious diseases using ELISA now. This enteric, this HIV, this hepatitis, so many autoimmune diseases that you diagnose with ELISA. Then comes microarray. Now, microarray is basically microanalysis. So you go down into the DNA and uh, into the chromosome and find specific genes, and those genes you detect their mutations. So it is a screening tool. It is not a diagnostic tool. It is a screening tool. It screens for multiple gene mutations simultaneously. So let us say you have a cell, a tissue in the breast, which you want to diagnose for the presence of gene for HER2/neu, for mu receptor, for estrogen receptor, for progesterone receptor, ERPR. Then how do you do that? You screen them with microarray. If the microarray uses and multiple gene mutations like BRCA1, BRCA2, simultaneously you can test with the microarray test. For example, cancer profiling and using them in pharmacogenomics. Nowadays, it is an upcoming branch where the drugs will be synthesized as per the individual's genetic makeup. Then is karyotyping. Karyotyping is a very beginner level diagnostic technique where you actually detect gross chromosomal abnormalities. For example, XO. So one X chromosome is absent. How do you do that? You don't need to do gene mapping here. You don't need to do microarraying here. You don't need to do ELISA here. All you need to do is karyotyping. 20. Down syndrome. So 13X. Okay. So this was about the genetic testing technique. Then comes the molecular oncology and using the pharmacoagents for targeted therapy. In this, the leader is CRISPR-Cas9. So this is basically a gene editing tool. Nowadays, everybody is using their mobile phone to do photo editing tool. So there are filters, there is, you can copy the pictures and do everything with a crop tool and all. Same way, CRISPR-Cas9 is a format where they are using micro scissors. So these are gene editing tools which allows precise DNA modifications. And you can, for example, somebody has a gene which has a mutation and that mutation is causing cancer. So if you can just use these micro scissors and cut out those portions which are causing the cancer, then probably you can treat the person. For example, let us say here is the problem. So in CRISPR, what you can do is you can simply take out this portion using the micro scissors. And then when this is removed, it will reunite it like this. And the blue portion is literally lost with the seizures. So that is lost. Hence, this uh, mutated gene will be taken away, the oncogene will be taken away, and the cancer potential will decrease. So these are the newer interventions that will be utilized in coming future, and they will become a routine things. Then comes RNA interference, that is siRNA. This is to use what? This is the RNA which is uh, going to connect with ribosomes and produce a protein. Now, if I use an anti-RNA and it binds to it so that it cannot enter into the ribosomal complex, then what will happen? The gene is there. It is this DNA is there. This is producing the mRNA, but this mRNA cannot translate now. That means we have saved somebody from a potential gene mutation related disease. Now the patient cannot produce that protein because we have blocked that protein synthesis at the level of the mRNA ribosomal complex formation. Now, this would help in management of diseases like Huntington's disease, like the Alzheimer's dementia, because tau proteins are getting deposited there, and proteins are being translated from some RNA only. No, some mRNA only makes some proteins, and tau proteins and these TTR, so genes which are now, we understand that they are the ones which are producing amyloid. So you can block the production of those proteins by using RNA interference or siRNA. Is that clear till now? Yes. Then coming to oncolytic virus therapy. Now, these are engineered viruses. You all know that a virus is like a nucleoprotein molecule. Now, this virus has a DNA inside. This virus has a DNA inside. Uh-oh. This virus has a DNA inside. Now, what will happen is, for example, if we have given it to someone, and this virus has receptor only for cancer cells. For example, this is the cancer and this is the receptor. So this virus will go and attach here, and there will be this DNA. Now this DNA will be introduced into this cancer cell, and this DNA will align itself with the rest of the DNA of the cancer cell. Now what will happen is, this virus will ultimately make its own DNA. So it will utilize the cancer DNA to make its own DNA, until what will happen is, this will explode the cancer cell, releasing further copies of this virus. So, and then this will continue to infect the cancer cell and killing it completely. So there are chances that this one can be used. In fact, one of those molecules, those oncolytic viruses, are already in use. For example, in melanoma, which is a skin cancer, and the virus is Treg. Then comes a CAR C cell therapy, where what we have done is we have altered the T cells. Now we understand the T cells are either CD4 or CD8. Now CD8 cells, they are basically killer T cells. They are the ones who are responsible for killing the cancer cells. And CD4 are basically for stimulating the B cells. They become memory cells and letting the antibodies cascade. This is CD8 is the killer cell. It is helpful in managing cancers. So these T cells, if you can genetically modify them, then they can be used. For example, B cell lymphoma mein CD19 wale altered T cells can be used. And then definitely everybody nowadays knows that monoclonal antibody therapies are being used, which are known as biologicals therapy, biologicals or immunologicals. This is what they are told. So these are target specific antigens. For example, trastuzumab is the most famous HER2 new breast cancer drug. So these are chimeric molecules, and they are a big name now because they have helped treat so many people with least of the problems of chemotherapy. Then adeno-associated viral vectors. This is also used in gene therapy, trying to eradicate or modify the gene. So used in Duchenne muscular dystrophy. Then coming to newer further techniques, which are pharmacogenomics or precision medicine, where you understand the condition and disease so much so that you know that you have to block the mutations. These are the drugs like EGFR inhibitors. So wherever there is something known as EGFR, endothelin growth factor uh, receptor, wherever this is there, and it leads to proliferation of the cancer cells, for example, non-small cell carcinoma of the lung, then these EGFR mutations can be blocked by erlotinib or gefitinib. These are the newer drugs, again biologicals. Then KRAS mutation testing. KRAS mutation is basically it provides resistance to the anti-EGFR drugs. So these are the EGFR inhibitors. So if somebody has a KRAS mutation, then this EGFR receptor will be altered in structure. So KRAS mutation should be tested before using any anti-EGFR drugs, specifically in colorectal cancer. So this is its use. When we saw why are our drugs failing in colorectal cancer, when it there is a potential pathway of EGFR receptor, and the drug should be blocking it. But what is happening is that the receptor has altered its structure due to the KRAS mutation. The gene got mutated, the receptor got mutated, and hence our drugs which were going to bind to the KRAS receptor cannot bind anymore. So the drug will be ineffective. It is prudent, it is wise to test all these patients of colorectal cancers if you are going to give them KRAS anti-GFR drugs, to test them for any KRAS mutation. Same way, CYP cytochrome P450 enzyme testing. Now, who knew that somebody who is given clopidogrel for keeping the cardiovascular coronary stents open will be rendered ineffective and the clot will be formed? Why? Because clopidogrel is not showing its effect. Why? Because the patient has a defective cytochrome P450. So the metabolism variability can be predicted if you can check cytochrome P450. Same way BRAF mutation testing. Why? Because BRAF mutation, if present in melanoma, it is an indicator that it will respond to a drug known as vemurafenib. Then TPMT enzyme, everybody knows it. It has been asked in the exam for last 5 to 10 years now. So TPMT is thiopurine methyl transferase enzyme. It is absent in certain population, and when the TPMT is absent in that population, if you give them azathioprine, they can develop bone marrow depression. Why? Because azathioprine azathioprine is a drug which is used in so many autoimmune disorders, even rheumatoid arthritis, SLE, Sjogren syndrome, myasthenia gravis, so many drugs, so many conditions. This drug is used. That if the TPMT is absent and you continue giving azathioprine, it will not be metabolized in that person, and it will start showing its toxic effects, leading to bone marrow depression, hepatic failure, and so on. So it is very, very important to test for TPMT enzyme activity. Then HER2 new testing, PR, ER, receptor testing. This is very important now because we have to give a drug which is known as Herceptin, trastuzumab, in breast cancer. If HER2 receptor is present, then it will show its effect. If it is not present, then it will not. Then checkpoint inhibitors, new drug, pembrolizumab. Pembrolizumab is the drug of choice now, which is used for a condition known as triple negative breast cancer, TNBC. So you should check that patient has the PDL1 expression. If the patient has PDL1 expression, then pembrolizumab will be working very good. It is used in NSLC, melanoma, breast cancer, triple negative breast cancer. So very good drug these days used. It is expensive but is effective. Same way, ALK inhibitors like crizotinib, elastinib, these are used in non-small cell cancer of the lung.